Hey there, welcome to chapter 26 of the Emergency Care 13th edition EMT class. I'm Kevin with EMS Abound. So we're going to run through this chapter, and it's available for both my students. It's available for you to study if you're not one of my students, and it's available as CEUs all on my YouTube channel. I was messing up my social medias there. Sorry about that. So first off, soft tissues. What makes up soft tissues? Everything that's not hard, that's on the outside. Think of it that way, right? Skin, which, epidermis and dermis. Epidermis being the outer layer of dead skin, which is continuously sloughing off. Underneath that's the dermis, which provides that layer of living tissue. You've got veins and arteries and nerves, sweat glands, all the things that allow your skin to do what it needs to do. Under that, we've got subcutaneous tissue, fatty tissue. Muscles. Muscles provide that movement of our bones and also protection for our organs by being able to tense up, contract. Blood vessels, all right, so arteries taking oxygenated blood out, veins bringing deoxygenated blood, back, and then the capillaries where that gas exchange actually takes place. Connective tissues are the things that connect bone to bone, ligaments, and then muscle to bone, which are tendons. Membranes, so we have membranes covering organs, we have membranes covering muscle groupings. So we have these things called compartments in large muscle groups, where within that pocket of tissue, that membrane, fascia, is a very tough, fairly inelastic tissue. And the problem with that is we can develop what's called compartment syndrome. So if we damage muscle or vessels within that compartment, it swells like you expect, but that fascia cannot expand as much. So if you ever hear compartment syndrome, that's what we're talking about. Glands that secrete things, and then nerves that are both for sensation and motor, right? You know that you can pick up your water bottle because you can feel it, sensation, but the ability to grasp it and bring it to your mouth is motor. So here we have inner linings, right? We have the lungs, and we have the parietal linings for that. And then we have intercostal muscles, which are the muscles between the ribs. Very tasty if you cook them right, of course, from pigs and cows. Muscle, which allows movement and protection. Fatty tissue allows for insulation and protection. And then our skin is a semi-permeable membrane. It allows you to get rid of some things like perspiration to help cool. And it protects you, though, from outside water, like rain. So the protection, water balance. If you need to excrete some water, right, we tend to think of our urine. Well, we exhale fluid. We get rid of it through urine and feces, and we also get rid of it through perspiration. Temperature regulation, the more subcutaneous tissue you have, the warmer you tend to be all the time. And the less you have, the colder you tend to be. So you think about this 85-pound, 85-year-old female who has 7 layers of clothes on in July and her thermostat set to 95 because she's cold all the time, right? But it also does cool things like goosebumps. If you get cold, you develop goosebumps, which increases the surface area of your skin to pick up heat from the environment around you. And then shock absorption, impact. It allows protection for the organs underneath. I've already mentioned these. Epidermis is a dead layer. The sebaceous glands within your dermis secrete oils up along the hairs, say on the back of your arm, and that helps keep that epidermis moisturized and not flaking off. Wounds get classified as whether they're a closed wound or an open wound. So this is a great little diagram, shows your epidermis. It starts out at the base as living, and then as it starts to die off, it comes to the surface and sloughs off. Piliary muscles give us the goosebumps. Our sensory receptors in our nerves versus the motor receptors to our muscles. Sebaceous glands, you plug one of these ducts up and you get that big sebaceous cyst. I don't know. I don't get the whole Zit Popper TV show and the people's love for it. Maybe it's because I've seen too many of these in the ER, and when they cut into them and they let go, it'll stink the whole ER out. I have no desire to be around those things. Arteries, veins, again, transporting nutrients and oxygen and waste. Sweat glands, bringing fluid to the surface to allow evaporation, which cools the skin below it, temperature regulation. Now, closed wounds are just that, they're closed. There's no unbroken skin on the surface. However, you can have devastating injuries below it, and they can be life-threatening. You can have a little boo-boo, or you could have that devastating blunt force trauma to the abdomen and bleed to death from it. So contusions and hematomas. This one's very easy to confuse. Contusions are what we think of as a bruise. Oh, I banged into a doorknob walking past the door. I have a bruise on my forearm. That's small, relatively localized. Hematomas are larger, if you think about it, bruises, but they're caused by bigger damage, bigger vessels, more tissue involvement. It looks like a bruise, but it's big. Think about somebody who's bleeding internally in their abdomen and they develop a bruise around their belly button. That would be a hematoma. Okay. Now, that's not to say contusions can't be life-threatening. The one I can think of is a pulmonary contusion. It is a bruise on the lung, but that bruise on the lung of the lung tissue disrupts the flow of oxygen from the alveoli to the capillaries. Closed crush injuries, generally we end up rupturing solid organs when they get crushed. Solid organs, if you think about, you may eat liver now, or you may have been forced to at some point when you were a kid. But you think about liver, it's dense, but it's kind of easily torn. You don't really need a knife to cut it, but it's a solid organ. So if you can take a piece of liver on your plate during a temper tantrum when you're a kid and rip it and throw it in the trash can, you can do that also inside your body. Now, when we talk about blast injuries, we can have open and closed. You absorb enough blast energy, you can split skin, make it open, or it could maintain, your skin could maintain its integrity from the blast itself, but the secondary injuries from shrapnel, dirt, rocks, other people's teeth, whatever, can certainly cause you to have open as well. So little contusion, little bruise. Rupturing a hollow organ. So rupturing hollow organs is pretty difficult. In this case, we've got large intestine, small intestine. I'm not sure which one's ruptured there, but hollow organs bend and flex and squish. They don't tear that easily, okay? You can certainly puncture one, but and that would be a rupture also. But as far as blunt force doing it, it's pretty hard to accomplish. Internal injuries, in this case in the middle, you've got a rib that's broken and it's punctured the lung. You can have a crush injury and have it still be closed, but suffer, as you can see with this bone, and you imagine the tissue around it, some fairly significant internal injuries from it. And this is a great example of liver, a tear in the liver. So when we assess, right, we talk about secondary assessment, DCAP, BTLS, B for bruising, okay? When I'm looking at DCAP, BTLS, I'm not thinking bruising versus hematoma. I'm looking for bruising. Then I decide, do I think it's a bruise? Do I think it's a hematoma? Do I think it's big and internal, or do I think it's a localized external injury? And part of that is my mechanism of injury. So I slip on the ice and I twist my ankle. I get some bruising around the ankle. The mechanism of injury is that's a localized injury versus I have a bruise on my abdomen. I was unbelted and I went into my steering wheel. Okay, so mechanism of injury, and know that crush injuries are super hard to identify at times, because if you think about your abdomen and it's bleeding internally, it's going to take a little while for that to show itself externally. So with all things, standard precautions, right? If it's wet and icky and it's not yours, don't play in it. And if you're going to, wear your protection. Okay. ABCs with trauma, ABC, DE, right? Or XABC, exsanguating hemorrhage, airway, breathing, circulation, or one military's using that I've seen in some civilian textbooks, MARCH, massive hemorrhage, airway, respiration, circulation, and hypothermia. Okay. What's going to kill them first? If they're not bleeding to death, ABCs. If you think they're bleeding to death, then we address that first. And sorry about that. Extremities, splint them. Not only does it make them feel better, but you've got vessels that run next to these bones in a lot of cases. And you can have a wiggling, jiggling, sharp edge of a bone lacerate a big vessel. And then you've got a whole different patient complaint going on. Okay. Vomiting, certainly crush injuries, internal injuries, bowel injuries, that's super common, but also pain. Pain makes people nauseous. Nausea makes people puke. Our biggest concern with vomiting is airway. Okay? If I'm thinking internal injuries, then I'm thinking they're not stable. Their vital signs may be stable, but I'm going to look at them as reassess every 5 minutes. Isolated injuries, cold packs are wonderful. You've got that spun out ankle, splint it with some ice packs in the splint. Okay, surround that ankle with ice packs. Put a like a pillowcase around the ankle first, because you don't want cold directly against skin. Wrap ice all the way around it, 360. Put a splint around it, and then prop it up on some pillows and blankets. Ice elevation really do help with swelling. Swelling is what causes pain. Rest of our DCAP, BTLS, abrasions, right? Road rash. At some point in our life, we were running and fell down and scraped our hands on the pavement. And we looked up and we had little chunks of tar embedded in our hands, but we were kind of oozing this clear fluid. That's an abrasion, road rash. You can have local, like on your hands, or you could come off a motorcycle wearing t-shirt and shorts and have head to toe road rash, okay? Lacerations, are they jagged? Are they straight? How deep are they? What caused it? Can you control it with direct pressure? P, penetrating and punctures, okay? Penetrations, entry and exit wounds aren't always in a straight line, okay? They hit things inside and change direction. So what I do with punctures or penetrations is I look at what caused it. How long was the object? If it's a knife, how long was the knife blade? And I give it an extra inch or two. based on force of it going in a little bit deeper and then rebounding back with the muscle, fat, and skin. So I look at that 4-inch knife blade and I assume 6 to 7 inches. What could it reach? If I'm looking at a gunshot wound and I have an entry at my right hip and an entry at my left, an exit at my left shoulder, or I think it's entry exit, it doesn't matter really. I got 2 holes. What is in between them? Okay. Avulsions, that big flap laceration. You think about a V-shaped chunk of skin with a tear, and it kind of rolls up like a nightshade. Okay. Amputations could be partial or incomplete, like a finger that's mostly chopped off, or it could be complete. And we'll see some pictures of some of these things shortly. Crush injuries, we've talked about closed. Well, you can have open crush injuries. The skin gets torn by the force of the crush, or it gets split by the force of the crush, or what's underneath it penetrates out through the skin. Bites. Humans are notoriously dirty. They're far dirtier than most animal bites, by the way. Blast injuries and high pressure injection injuries. So when you're looking at a wound, do I need more than just gloves? Well, if it's spurting or spraying, you may want something over your eyes, and you may want something over your uniform or your clothes. Can that open injury hurt my airway and breathing? Certainly. If it's anywhere near the lower airway or upper airways, right, around the face, it certainly could. Strict attention to standard precautions. So somebody spraying blood out of a lacerated femoral artery, they're already behind the curve because it happened before you got there. I'm going to kneel on that thing. I'm going to put some pressure on it. I may literally kneel on it. And then I'm going to worry about the other stuff. I can wash my uniform. I can take a shower. But if I take 2 or 3 minutes digging through the back of my ambulance looking for gowns and gloves and face shields, oh my, this dude could be dead. On a National Register exam, of course, you always want to put this shit on first. If it's me laying on the ground bleeding, I'm begging you, just kneel on it and then worry about your PPE. So care, expose the wound. You can't examine it and assess it if you can't see all of it. Okay. If it's an extremity wound and it's isolated, then if it's a forearm, I'm going to strip up to the shoulder. If it's the leg, I'm going to strip them up to the hip, and I'm going to look from hip to toes, shoulder to fingers. I'm going to get it exposed. If it's not spraying blood and I'm not worried about them bleeding to death, I'm going to clean it off, right? Part of this, our job is to prevent infection. So if we can rinse, let's say, some road rash off, get some of that dirt and crap out of it, then wipe around the edges of it, and then put some form of bandage on it or cover on it, we've done them a great service, right? Above all else, do no harm. By doing something to clean that wound, we're preventing harm. Okay. Now, bleeding, control the bleeding, direct pressure first and foremost. And if you don't think that's going to work, then direct pressure while somebody puts a tourniquet on. Okay. Hemostatic dressings, the quick clot as an example, great, and we'll go into those a little bit more. Serious wounds, high flow oxygen. Trauma patients need oxygen. We talk a lot about medical patients and that magical saturation number of 95 and above. Trauma patients burn through more oxygen than your typical medical patient will. Okay, they get cold quicker, which burns through more oxygen. They're trying not to bleed to death. That sympathetic response to bring platelets to the wound site, to bring white blood cells to the wound site, increases metabolism, burns through oxygen. Okay? And again, prevent further contamination. If they're bleeding to death from something else, worry about the road rash later. But do what you can when you can. We're going to put bandages in place after bleeding's controlled. So this is the textbook method. In the street, what you see is we throw a 4x4 or a 5x9 on it, then we wrap it nice and tight, nice pressure dressing, and we have the patient elevate it, and then we look back 5 minutes later and we're like, oh, geez, it's still bleeding. Well, put some direct pressure on it. Take that 4x4 in your hand, put it on that arm, and push and squeeze. 5 minutes. Get that controlled, get that bleeding controlled. Then we can put a dressing over it and go on to something else. All right. Don't walk the bleeding patient to your truck. Right. The only kind of time I vary from that is if extrication is going to be extended. I can walk this patient 15 feet quickly in a matter of 10 seconds, 15 seconds, and put them on the stretcher versus going to take us 10 minutes to, put the patient on a carrying device. There are times where ambulate before carry makes sense, but only when it makes sense, okay? Because you don't want their heart rate climbing any higher than it already is. Reassure the patient. Abrasions, lacerations, again, contamination, direct pressure to control the bleeding, and then before and after you do anything to an extremity, motor, sensory, and pulses, right? CSMs, circulation, sensation, and motor. If you're just trying to put a dressing on a laceration, you're not putting a tourniquet on, you're just putting a dressing on it, and you check afterwards and you put it on too tight, you don't have a pulse, crap, loosen it up, okay? Penetrating trauma. It's kind of like that, the lettering on your rearview mirror in your car. Objects in the mirror may be closer than they appear. Also a great Meatloaf song, by the way. But this is why I give that an extra couple of inches from that penetrating, that 4-inch knife. That 4-inch knife, try that again. That 4-inch knife may have only gone in 1 inch. I took care of a guy who tried to stab himself with a paring knife, and he had 45 or 50 puncture wounds on his belly and chest. The majority of them did not penetrate through subcutaneous tissue because every time he started, ow, and he'd yank it back because it hurt. And then he'd get pissed and he'd do it again. But we had to assume of these 45 or 50 that several of them or all of them penetrated through into his abdomen and or his pleural space. So, we put dressings on that sealed those wounds, right? Just until like the CAT scan proved otherwise. You have to assume, okay? Bullets hit bones, bones splinter, and now you've got 37 little fragments blasting through the tissue as well. Stab wounds, I would rather be stabbed than shot. Stab wounds damage what the knife contacts. So if the knife does not, they're painful, right? But if the knife does not hit a vessel of, a decent sized vessel, it's not typically that serious a wound in an extremity. Okay, in the torso, right, we've got a lot more big vessels, and we also have the thorax and pneumos and hemos to worry about. But if the knife misses, it's not as serious. A bullet, though, imparts some energy at a higher rate of speed, and it's got a wider cross section to it, so a wider radius to it, and in all directions. So that imparts some energy to the tissue as it's passing through, and that tissue then imparts energy on the tissue around it. So you can have within that bullet path, you have an exact bullet track that damages whatever it hits. But in that cavitational sphere or zone around it, you can have some damage that from the bullet's energy, not from the bullet itself. Reassure the patient. Look for an exit wound, absolutely. And it's not important to know whether it's the entrance or the exit. And people go, and you hear all kinds of bullshit about this. You can always tell the entry wound, right? A 45 goes in 45 and it comes out the size of a trash can cover. No, it doesn't. I have seen a lot of through and through gunshot wounds, and most of the time, I don't know. I can't tell the difference. Maybe if it's a 50 cal or something, you know, but most of them, you can't tell the difference. Some of these people don't even know what direction they were shot from. So that doesn't help us any, right? Local protocols as far as spinal immobilization, if it's in the area of the spine, in other words, that tract, whether it's the edged weapon is close enough or at an angle that could hit, or that bullet path could have impacted, then yeah, we're going to think about spinal restriction in most states nowadays. This is a great little diagram. You can see that this bullet has changed direction. It hit a rib, shattered the rib, which is going to blow chunks of rib into the lung, came out through the bottom of that lung into the liver and hit more bone as it went. So we've got thoracic and abdominal injuries with this because it's right there at the base of the lung, right where the diaphragm. You're also going to have the diaphragm involved. So, you know, is this an entry or an exit? I don't know. Couldn't tell you. I know he bled a lot, right? I mean, he is covered in blood. His underwear is covered in blood. So obviously he was standing up or sitting up for a while because the blood ran downhill, and it's continuing to leak. So for this dude, right, direct pressure, well, that's not going to do anything. Direct pressure on this is just going to take care of the outer edge, that outer skin. It's not going to fix the intercostal and the rib and the lung, all right? Hemostatic dressings. Again, just the outside. It's not going to fix all the way through. What this dude needs is a trauma surgeon. Impaled objects. Do not remove the object unless, of course, it's in the face and it involves the airway. We'll see that. But the problem with impaled objects is you could have, think about a fish hook or an arrowhead, right? You've got an arrow. This is the guy's skin. The arrow goes in, and as this slices its way, arrows are still spinning and rotating. So when it comes to a stop, this is not going to line up to come back out through that nice little cut it made. If you pulled on this, you're going to cause a lot more damage as it comes out. And people, well, it was a regular tip. Okay, maybe it was, maybe it wasn't. Now, maybe it's a stick, and this stick goes in, and that stick has a broken off little branch. Same thing, okay? So we're going to leave those in place because we don't want to create any more damage than has already been done. So what we need to do is then immobilize it, okay? We need to try to do what we can for bleeding with direct pressure without shoving the arrow further into a spleen. And we want to apply big bulky dressings. So multi-trauma dressings are 10 inches wide by 30 inches long. Roll that thing up, wrap it around it, layer them around it, kind of like a log cabin. If you think about the way a log cabin overlaps at the corners, do that until you've got this thing as secure as you can, and then wrap cling or ace bandages, whatever, around the body to hold that in place. The idea is that the less wiggling that does, the less damage it causes. Care for shock. So how do we do that, right? Right out of our trauma assessment station, we're going to keep them flat, we're going to keep them warm, and we're going to keep them oxygenated and or ventilated. By keeping them flat, they're at rest, and we do want rapid but safe transport to the appropriate facility and reassure them again. So this is a great little example. These are 5x9 dressings, and they're just, they've got the patient holding it himself. Okay, we know this is make-believe, and he's actually holding the stick, but have the patient hold it while you put these in place. Then you can start to wrap it, and he can pull his fingers out. Perfect, right? The idea behind that is whatever damage has been done has been done. Now somebody else can go in there, widen out the original injury a little bit, see what it involves, x-rays, CAT scans, MRIs, whatever they want to do, or exploratory. But we're not going to allow this to get worse by jiggling it or letting it jiggle around. Now with the cheek, the problem with the cheek wound is that blood into the airway, and also vomiting. This could obstruct the flow of vomit and cause them to aspirate. So the thing with the cheek is you can reach in there and feel that pencil, feel the tip of that pencil, and where is it? And the other thing you can do with that is by sticking your finger in there, you can actually pinch both sides of the wound to apply pressure. And this would be a great wound for just a little bit of quick clot, either a small quick clot gauze or a little bit of powder, and then just hold pressure on both sides. Now, if you're going to do this or you have that facial injury, allow them position for drainage. So I like to transport these people on that side. So damage side down. Put a dressing on the outside, sure. But I'm going to sit there and hold that until I think it stopped bleeding. And, you know, you're between the cheek and his teeth, you should be out of damage, you know, out of concern as far as being bitten. You should be safe. But the other thing you could do is have him do it. Here, stick your thumb in there and pinch it off and keep holding it. He's not going to bite his own finger. And then treat for shock. In the eye. So in the eye, same thing. You want to secure this. The other thing you need to do with this is cover the opposite eye. Eyeballs, well, pupils should react equally together, but eyeballs also move equally together in 99.9% of the population. So if you leave that right eye open, uncovered, and somebody to their right side says something to them, as they turn their head, they'll move their eyes first, and so that damaged eye will move also. But if you cover that right eye, they'll turn to the sound, and you're going to help prevent further damage. Now, putting a cup over it is, if it's small enough, short enough, is a great thing to do, because again, it will help. If somehow somebody bangs into that, it's going to hit the cup, not the stick that's in her eye. Oxygen, treat for shock, and emotional support. Yeah, this one, reassuring and emotional support. This is going to be one where they're going to be pretty upset. Take them to, if you are close enough to Mass Eye and Ear, yeah, you take them to Mass Eye and Ear. Otherwise, you know, we're going to take them to a local ER, and they're going to end up transferring them to probably Mass Eye and Ear. Would I fly somebody like that? Yes, I absolutely would. You know, I walked in and I saw that. The first words out of my mouth would have been in the radio going, hey, get me a helicopter. So, avulsions. I've already described these as kind of like a V shape. That's kind of your typical tear. Clean it. These will ooze a little bit. They're not typically, unless it's, most of the avulsions we see tend to be thinner skin on older people, especially the folks who are on the chronic meds, the steroids especially. And so we kind of rinse it off and clean it off a little bit, unroll that skin back to where it should go, and then we put a dressing over it and keep it wrapped. If that skin has been torn off, save it, put it in a sterile dressing, a little bit of sterile saline on it, and then transport with the patient. Which is also kind of how we're going to deal with amputations. We're going to wrap it and protect it. Some sterile dressings, moist sterile dressings are okay. We do not want them on directly on ice. We do want like to keep them cool, you know, put some ice in a cooler, put something over the top of the ice, and then the injured body part, the amputated body part. You got to remember that with amputations, there's no blood flow to that anymore. So if there's no blood flow and no muscular control, nervous control of the muscles, they can't maintain the heat and protection of that skin. You put that skin straight down on ice, great, they've got an amputated foot with frostbite. Nice job. Okay, now amputations, direct pressure. If you have a finger, an amputated finger, yeah, pretty much direct pressure will work. You can get direct pressure on that finger. It's going to hurt like hell, but you can do that. But if you're talking a wrist, a forearm, a humerus, a lower leg, just go to a tourniquet. It's weird. The book has been very good. This edition is very good about talking about tourniquets. But every once in a while, use a tourniquet only if, no. If you're talking a big limb or a big portion of a limb, just go right to a tourniquet. So, looks like a thumb to me, right at that distal interphalangeal joint. So he's got it on some 4x4s that are moist. I would cover it with 4x4s that are moist and a little bit of ice and transport it with that patient. Do not immerse it in water or saline. Keep it, you know, on something moist is okay. The only kind of the one that goes against that are teeth. Teeth can go in like a cup of milk. Milk, I don't remember what it is, but milk helps protect the maybe it's a dentine, something within the tooth. Genital injuries. Everybody's going to be upset by this injury. The patient's going to be upset by it. You as a provider may be upset by it and nervous and anxious. So everybody needs to take a deep breath and be as calm and professional as you can. Treat it appropriately for what that injury is. If it's a laceration, yeah, direct pressure, or quick clot, or the treatment for the avulsed part, right? Rinsing, folding skin back, etc. You got to think about sexual assault with genital injuries, right? If you're getting a weird story, and you don't necessarily have to be the big chief detective on this, but consider it, and especially if it's a minor, bring it to the attention of everybody, police, ER, and file the appropriate paperwork for it. Burns. So we're going to see some pictures of different examples of burns. You can have just localized first degree skin level, external, right? The dermis, basically, an epidermis, or you can have deeper. You can also have them on the torso where you're going to affect the ability to breathe. If you have a circumferential burn, so a burn that goes all the way around the chest, I want you to think about burning a piece of steak, right? You've cooked steak or chicken at some point in your life and you burned it and it shriveled up and it got tough. That's what happens to burned meat, which means your skin, your epidermis, your muscles, they will shrivel up and get tough. That will not allow expansion of the thorax to have respirations. You may be trying to bag this guy and you can't. The chest won't expand. This is, you know, an ER and a doc with a knife blade to make some fasciotomies, escharotomies, where they burn down through that burned tissue into fresh pink meat literally, and that allows now expansion for respirations. If you have burns around the face, around the neck, you can constrict airways, okay? So burns anywheres from the diaphragm to the mouth and nose, you got to worry about airway and breathing. Don't let these burns distract you from life-threatening injuries, though, okay? When we're looking at burns, what caused it? Is it a chemical burn? And what was that chemical? Was it a flash burn, like they were goofing off with gasoline and a match, and they had a flash of flame? Okay, how deep is it, and how severe? What's the percentage of surface burned? So it could be electricity as well. When practicable, report what it was, right? When practicable, quoting Robert E. Lee now. But don't assume what caused it. Try to find out for certain what it is. Different chemicals have to be treated different ways. Okay? A little diagram, we'll see some actual photos in a minute though, but superficial, it's just basically the epidermis. It might, it's a little red. It hurts. It can hurt like hell. Think about your sunburn. So it's not just the epidermis, it's down into the dermis because it's affecting the nerves. Partial thickness, you are now involving more tissue. A lot of times you get blistering and a lot of weeping from this area, which leads to fluid loss. And then full thickness, so 3rd degree, you can see it's down into deeper into the dermis. You can also have it as far down as fat or muscle. Charring. These diagrams do us a great disservice. A lot of your full thickness 3rd degree burns are not going to be black or brown like charred meat. It may just be white. It may look waxy, okay? But think about shriveled, burned meat. 1st degree, again, only the epidermis, but you've got some swelling below it, and that's causing some pressure and pain. Partial thickness down through the dermis, deep intense pain, lots of reddening, lots of blisters. And then 3rd degree, so blackened areas, so charring, surrounded by dry white patches. I took care of a 90-something% 3rd degree burn from an explosion and a water heater explosion. And there was no black areas, none whatsoever. It was like 3 in the morning in the back of an ambulance when I did the intercept. And my initial impression was, oh, she didn't look too bad. Then I stopped for a second and took a closer look and went, that's not normal appearance of skin, okay? It was all dry and white. So don't go just on black and char. So your typical sunburn, 1st degree, superficial. 2nd degree, a lot of times this looks to me like fluid, like hot water. Got some up above. You can see where he had a tank top on, right? He's got some on the arm. It's very nice that they put the blood pressure cuff on the arm that has some red area versus the right arm, which has none. Dumbasses. But you've got some blistering. Again, 2nd degree, you've got some blistering. It's wet. I mean, I think that's kind of the difference between a lot of these. You can get wet with 3rd degree also, but you're not going to have this blistering wet look to it. Charring, black, yellow, charring, peeling skin. Oh, look, this pink skin. Yeah, that's because that's underneath what has already peeled away. You can see this peeling away. This white is what I was seeing, okay? Now, look at this guy's airway. He has burns circumferentially around his neck, up onto his face. He's in a medical facility. He has a non-rebreather on. He is not intubated. They are way behind the ball on this dude, okay? This guy needs to have an endotracheal tube to protect his airway. He's going to need some plastics. Part of his earlobes burned off, right? Circumferential, I'm worried about his ability to ventilate, right? So ER, even if you take him to the local ER, you got to give him plenty of notice. Hey, I've got circumferential burns. I'm worried about being able to ventilate him. The ER doc can call in a surgeon, or the ER doc can do it. Okay, but this is going to need to be addressed. So again, what was the source of the burn? What body parts were burned? It sucks to burn a toe, but burning a toe is different than burning your mouth, okay? It has different mortality rates, okay? How deep? What's the extent? How old's the patient? Very young, very old don't do very well. And what is their underlying medical conditions, right? Are they on beta blockers, and therefore they're going to have trouble compensating? So let's look at our rule of nines. Rule of nines is a nice, I think of it as a 2 a.m. rule, right? Where even at 2 o'clock in the morning, you should kind of be able to figure this out. Adults, we go based on everything except the hoo-hoo is worth 9, right? And guys are especially like, oh, that's worth more than 1 point. No, it's not, okay? If it's worth more than 1 point, you're not normal, okay? So head is 9. The upper front chest is 9. The lower front belly, right? The front chest is 9. The front belly is 9. The posterior back is, chest, which is the back, is 9. The lower back is 9. Front of the leg 9, back of the leg is 9. The entire arm is 9. So this 4.5 kind of throws people a little bit. Arm is 9. Leg is 9 plus 9. 9 plus 9, 9 plus 9, and 9, okay? Kids' heads are proportionately bigger in comparison to the rest of their body. So a kid's head is 18. Their arms are still 9. Their genitals are still 1. Chest is 9, belly's 9, upper back 9, lower back's a 9. But we're going to take a couple of percent off each leg to give us that 18 for the head. And the kids are the same. I hate charts that do this. 7 back, 7 front. Oh, 14. Well, no shit, okay? Anyways, one of the other ways you can do this is called the palm rule. The palm, the patient's palm, not the fingers, not the thumb, the palm is worth approximately 1%. So if you think about the genitals, you can cover that with 1%, with your palm, that's 1%. So you're using their palm. Now, let's say this guy and I am the same size. We're both 5'11", right? I can take my palm and I can, let's say it's an isolated burn. It's here. I can either call that 4.5%, or I could go palm, 2 palms, 3 palms, 4 palms, and a half a palm, okay? You've got a burn on his calf, and you take your hand and 1 palm covers it, that's 1%. This little kid, his palm is 1%. Okay? So we use this to try to figure out where we're going to take this patient. Okay? What do we need to do for care as well? We need to worry about hypothermia. A 1% burn on the back of his leg, you could put a wet dressing on that and it's going to feel better. The guy burns a couple of fingers. You can run that under the sink and it's going to feel better. You take that 10% or more burn and you make that wet, you're now running the risk of hypothermia. Okay? Moderate burns in a young kid can be fatal to an older adult. Keep that in mind. Kids' body surface is also bigger proportionately than our skin is. So any burn they have is worse than a burn I would have. They have greater fluid loss and greater heat loss. Sorry, try that again. Greater heat loss. Now, stopping the burning process and cooling the area. If their clothes are smoldering, get the clothes off them. If they are still exposed to the heat, get them away from it. If it's chemical, brush the chemical off of them. Okay. Cooling the burned area, it once you've gotten them away from the source, the burning is going to stop. But cooling it makes it feel better. Okay. ABCs, airway. I cannot stress that enough. If you have any sign of airway injury, the nose hairs are singed. There's soot around their nose or mouth. There's swelling around their face or lips. You got to be worried about an airway. And that patient, I am going to be more likely to start transport maybe a little sooner than I would otherwise, because I want them someplace where somebody can intubate them. Call in for a medic, have them meet you on the way. Worst case, they don't intubate and they just ride with you. That's actually not the worst case. The worst case is their airway swells and they die. Okay. Treat for shock. As far as thermal burns, clearing debris is called debridement. We don't debride wounds. We don't debride dead skin and dead tissue. Okay. We do, however, remove clothing. Now, if there's clothing burned into it or charred into the burn, don't rip it free, please, God. Cut around it. Get as much of it out of the way as you can. Get jewelry off that extremity. Okay. Any extremity that has potential for burn, all that jewelry needs to come off. Dry sterile dressings. Chemical burns, brush it away first if it's a dry chemical, then lots of water. Or if it's a wet chemical, lots of water. And when I say lots of water, I'm not talking a cup. I'm talking, if all I have is a garden hose, I'm going to use that. But if I have an engine company on scene, I'm thinking trash line. I'm thinking an inch and a half with a lot, we don't need to be flowing 150 pounds, but a lot of water, okay? Because some chemicals respond very poorly with water. And by that, I mean they like flame and burn, okay? So to be quite honest with you, I would have him wipe his arms off and I would stand back. I would also make sure I was upwind. I would have somebody cutting his sweatshirt off from the backside so we can fold it out and around him like a dirty gown. All right. I'm going to get his pants off of him as well while this is being brushed off. And then this is not this. I don't think of this as flooding. This, when I was a kid, we turned the hose on this hard to drink out of it. I know some of you that freaks you out that it wasn't filtered, it wasn't bought at the store, but yes, we used to drink out of hoses. Okay, this is safe to put in your mouth. Your airway would be safe with this in your mouth drinking. Okay, this isn't even waterboarding for Christ's sakes. So this is not, in my mind, enough water. Get rid of that clothing. Dry, sterile dressings over it. Treat for shock, transport. Radiological burns. Now, there is risk with some of our hospitals, right, that somebody could be exposed to radiological equipment, right? They use nuclear medicine in the hospitals. We have nuclear power plants. What we need is somebody who's been trained to decontaminate these people before we deal with them. The problem is some of these folks, we may not know about it until after the fact, okay? So if you know it's a radiological burn, these folks, need to be decontaminated. Seabrook Power Plant, Florida, which is owned by Florida Power and Light, but they have a very intensive training program for their people. They also go to the hospitals that are their primary receiving, like Exeter. I don't know if Anna Jakes, I would imagine they probably do a little bit with AJ, but they go in and they provide this training. The ideal is, though, that they get decontaminated once at Seabrook, then they get deconned again at Exeter. But there's the risk that we run into these people, and if they're starting to spout off, they got exposed to XYZ, then stop. Do not come near me. Right? We need to have them. They now become what's the hot zone, and they need to be decontaminated. A lot of these do respond or react, present like thermal injuries, heat burns. Now, electrical injuries, electricity goes to ground. I'm not an electrician, okay, so I'm not, I don't know all the little intricacies of it, but I know that it likes to go to ground, and it will take the path of least resistance. So water is a path of least resistance. So electricity will go through water to ground faster. 60 some odd % of our human body is made up of water, including all the blood that is in our vascular system. So electricity will travel through our vascular systems to find ground. They will also travel nerve pathways because, again, path of least resistance. Electrical injuries are kind of like gunshot wounds. Look for entries and exits, okay? And what you could or probably will see are some burns where you've got your entry and your exit. You may actually have holes, like blown out chunks of skin. It depends on the electricity itself. And this is where I get a little confused by electricity, but whether it's ohms, amps, watts, I don't know. I know the bigger the numbers, the worse the damage is, okay? You can take a 9-volt battery, as kids, you talk your buddies into doing this once. Stick a 9-volt battery on your tongue. It hurts like hell, but it doesn't cause any significant damage. But you take a 110, much less a 220 cable, and you touch that, and it goes through you, you're going to have some significant problems. Cardiac arrest. Where in your cardiac cycle between your P wave, your PR interval, your QRS, your ST segment, and your T wave, where was your heart at that moment that the electricity passed through it? You could be in VFib, okay? You could also have broken bones. You could have muscles that are still violently contracting if they are still in contact with that electrical stimulus, right? So patient care, the one that's missing here is scene safety, right? If somebody is holding a 220 wire and it looks like they're seizing, they are. If you grab hold of them, so will you. Shut the power off first, all right? Then deal with them. ABCs, right? Burn care, etc. Spinal and head injuries, certainly, if they got knocked down, they fell down, they jumped backwards and fell, look at the burns, treat those the same way you would any other burn, sterile dressings, transport as soon as possible. 12 lead EKG. Anybody who gets tagged by electricity should get an EKG. All right, now, typically if this was a face-to-face class, I'd say, any questions about that? Let's go on to dressing and bandaging. We tend to use these terms interchangeably, but technically, so like if I was looking at a registry exam question, the dressing is that material, that 4x4. And when I say 4x4, that's how big it is. It's 4 inches by 4 inches, 3x3, 2x2, 5x9, okay? That material, or it could be the t-shirt that you tear off and put over the open wound. That is the dressing. The bandage is what goes around it. So this gets a little confusing. You think about an Israeli battle dressing, right? The Israeli dressing has the dressing and the bandage, okay? But we call it an Israeli battle dressing. So that's our dressing. That's a 4x4. And you put several on it, and then you squeeze and hold for direct pressure. A little elevation certainly isn't going to hurt. A lot of the studies now are saying elevation doesn't help, but I can tell you that elevation can hurt. So if you've got their arm below the level of their heart, blood is like electricity, takes a path of least resistance. So, it can pump uphill to your head, uphill to your feet, or it can pump downhill out of the hole in your arm. It's going to pump easier downhill. Universal dressings. So this is what I think of as the multi-trauma dressing. It's a big dressing. It's large. We can use any dressing and make it a pressure dressing, depending on whether we just simply wrap it gently or whether we wrap it tight and put pressure on it. Occlusive would be an airtight seal. So they make commercial occlusive dressings. But you could also take something that's just plastic. The plastic wrap that's around the dressing that you just opened up. The outer plastic bag from an IV bag, that you open up to get to the IV bag. And it's saran wrap, something that will not breathe and allows you to put that over the hole to seal that from sucking air into it. The belly. The reason we want air occlusive dressings over the abdomen is we don't want that very fragile tissue that makes up the intestines drying out. Okay? In the neck, the atmospheric pressure will allow air to get sucked into neck veins. Then you have a giant air embolus, which acts like a clot. Okay, we want to seal the chest so that we don't have air get sucked into that cavity, and the parietal, the visceral pleural space. Jesus, I was confusing it with the abdomen. Into the pleural space, causing a pneumothorax. Okay. So we put the dressing on, we wrap a bandage around it. Once you put that bandage on it, we don't remove that bandage, okay, because that dressing may have started to clot. There may be some clotting in that wound, and the dressing may be stuck to it. So if you start pulling dressings off, you could actually pull loose some clots. So our standard precautions: expose it, clean it, cover it, direct pressure if you can. Hemostatic agents or dressings in extremity injuries are great, but also in junctional injuries. Like what I want you to do is Google quick clot pig, and they do what's called the Black Hawk Down injury, where they lacerate a femoral artery and vein in a pig, and you watch it bleed, and you'll see why that old saying, bleeding like a stuck pig is there. But then they dump quick clot powder into it and apply pressure, and it clots right off. It's wonderful. So that was after a young ranger in Mogadishu, Somalia, died in 1993 during the Mogadishu raid from a injury in his groin where it hit either the high femoral artery or the iliac artery, and they couldn't get enough pressure on it. He couldn't clamp it off, couldn't tourniquet it, and the ranger died. So Black Hawk Down pig or quick clot pig. Bandaging open wounds. It's kind of if all you're doing is bandaging, you're not doing a pressure dressing, you don't want it too tight, but you don't want it too loose. You want to be able to slip a finger in underneath it to know that it's not too loose, okay, or not too tight. Tips of fingers or toes. If you are bandaging a palm, you want to leave the fingers exposed. You want the fingers to be able to move and bend in what we call position of function. But you also want to be able to assess that finger for cap refill. Okay? Again, just bandaging over a dressing. We're covering all edges of that dressing. So with any of these sorts of skin, muscle, bone type injuries, ABCs, right? Keep it simple. I've always preached this. Excuse me. Is my airway open? Will it stay open? Yes or no? Is the breathing adequate? Yes or no? If not, do something about it. Is my circulation good? Is it present? Right? Yes or no? So, do I have a wound? What should I do with it? Right? Is it bleeding? Yes or no? What's the best way to cover it? What's the best way to immobilize something? Do I have chemicals involved? Do I need to irrigate that? Geez, I tried to say does and do. Does my electrical injury have entry and exit wounds, right? The guy's got an injury to his hand from the outlet. It went to ground someplace. Check every place it was in contact with ground, right? So his feet, pull his shoes off, look at his feet. Okay? Have I bandaged this securely enough to hold it in place, but not so tight that it's a tourniquet? All right, so you got a 21-year-old male, anterior elbow. So it's the inside of his elbow where it flexes, also known as the antecubital fossa. There's lots of big blood vessels there. So he fell through a window, lacerated that area. There's a lot of blood. Bystanders have put a lot of towels and washcloths over the wound, at least 3 inches thick. That's great. Hopefully they're putting some pressure on it. There are so many dressings, though, you can't tell if it's still bleeding. He's alert, but pale and anxious. He's got a radial pulse on that the uninjured arm that's weak and rapid. So you know he's lost quite a bit of blood. He is at least in compensated shock, maybe decompensating. How much of that wound do you want to assess? You know, I mean, how much of that 3 inches of towel do you want to peel off before you make it worse, right? So if I walk up and they've got t-shirts and towels balled up, I'll start to peel things back and look. But when I get down to that bottom layer, unless it's like a dirty, oily rag, I may leave it in place. You know, if there's still blood gushing out of it, I know it's not working. Then I'm gonna throw a tourniquet on it, and then if that will come off, it comes off, and I'll start with clean. Okay. All right, so that is chapter 26 of the EMT book, Soft Tissue Trauma. If you've got any questions, you can certainly shoot me an email, emsabounds@gmail.com, or, you know, if you know me, shoot me a text, call me, whatever. Certainly leave comments once this is up on YouTube. Anyways, thank you for your time with me this afternoon, and I will catch you at the next class.